Hi, my name is Dr. Norman Wilson-Baig. I'm an ST7 academic trainee in the northwest of England in anaesthesia. My background also includes 15 years working as a pharmacist, of which 10 of those years was as a hospital pharmacist. 4 of those years was working as a hemato-oncology pharmacist, and 4 of those years as a pediatric pharmacist. Throughout my career, both as a doctor and as an anaesthetist, I've had to manage patients who've got diabetes. It is essential that we have an appreciation of on how we should approach these patients, and the reasons are thus. There's a 50% higher increase in mortality and morbidity in diabetic patients compared to the non-diabetic patients who undergo surgery. Why is this? It's multifactorial. One of the reasons is that the patients aren't identified as being diabetic. They come into hospital and then the team aren't aware of this, and so they don't get the appropriate care that they should get in order to minimize these adverse effects. The patients themselves have multiple comorbidities. They may have microvascular complications. So there's an increased, in fact, there's a 2 to 3 times increased risk of suffering with chest infections, surgical site infections, kidney infections, acute myocardial infarctions, as well as urinary tract infections. Myocardial infarctions can occur because of autonomic neuropathy. So this is something that you can get silent infarcts, which the patient might not be aware of as they're suffering with. Another issue is complex polypharmacy. These patients are on a lot of anti-diabetic medication. Some of them are on insulin as well, and various complex regimes which aren't standardized because it's bespoke to the individual, and so there can be errors that can occur when prescribing these medicines as well. There's inadequate hospital guidelines. Each hospital tends to have their own guidelines. I know there's national guidelines, etc., whatever, but depending on the locality, etc., sometimes these guidelines are inadequate. And as well as on top of that, the awareness of the staff and the training of the staff who manage these patients can be quite complex for the whole team to appreciate what kind of care is actually required for these patients. So what should we do? In our place for elective cases, a pre-operative assessment is essential. Looking at the HbA1c for elective cases should be definitely below 69 millimoles per mole, and this should be identified at the pre-operative assessment. If not, surgery should be delayed until it's actually less than 69 millimoles per mole. In old money, this is sort of like 8.5% HbA1c. The patient should be then referred, depending on how severe. I've come across patients whose HbA1c is 100, or even in the 110s, and these patients should be referred back to the GP or even to a diabetes specialist who can actually optimize their condition. As I said, these are for people who are undergoing non-urgent elective surgery. Other investigations that should be conducted, as with all diabetic patients, is a normal diabetic assessment, which just to confirm that they've had their sort of eyes checked and feet checked and all that sort of thing. And then you have the full blood count, using ease, looking at the renal function, and then also an ECG as well. History is looking for signs of autonomic neuropathy, so this includes for things like gastroparesis, signs of reflux, and that sort of thing. But what about the people who need an urgent surgery or semi-urgent cases? These cases, it's not as easy to manage the patient pre-operatively as you would for somebody who's having elective surgery. The stress of surgery itself can increase glycemic miscontrol of the individual, so blood sugars naturally go up because of the stress response. So therefore it's essential that we try and control the blood sugars in these individuals. With these, in the semi-urgent or urgent cases, it's essential to take a good history, explain to the patient the increased risks that they may have. Close monitoring is required before, intra-op and post-op as well. And in these patients, even if they're on oral anti-hyperglycemic drugs, these patients may need a variable rate insulin infusion, and advice must be sought from the diabetic specialist team if required. So what should we do for a plan? So these patients should be, this is once again for elective surgery, these patients should really be on first on the list, even if it's emergency surgery. I know in our case, sometimes when we manage the CPOD list, which is emergency list, we have a whole bunch of patients on that list for that day who need urgent surgery. If there's somebody with diabetes, these patients should go first, really, because we need to minimize the fasting period. We need to minimize the disruption of their diabetic medication and management routine, and try and get them back to what they were having. Sometimes it's not possible to do that, and so they may need to have a prolonged period of the variable rate insulin infusion, or once again, the diabetic specialist team can help here. What about those medicines that we were talking about for diabetes? Generally, all hospitals have their own guidelines on how to manage these things, like sulfonylureas, glitazones, DPP-4 inhibitors, GLP therapies. There's a whole host of medicines that these individuals can be taking, and on top of that, they could be taking insulin as well. So in type 1 diabetics will be on insulin. Some type 2 diabetics are on insulin as well. Most hospitals have their own policy. Generally speaking, most drugs tend to be stopped on the morning of surgery. However, there are some medicines, for example, the glitazones or the gliptins, that can be continued, but please check your own hospital guideline. What I will say is this, though: metformin is a drug that can result in lactic acidosis, especially in people with renal failure. Generally, people who have an EGFR of less than 50 generally, shouldn't be on this, but I mean, it's benefits versus risk. So obviously, with the stress of surgery and the risk of lactic acidosis, metformin should be stopped before the operation. Then there's other drugs which has recently come into vogue. You're talking about the sodium glucose transporter 2 inhibitors. These should be stopped at least 3 to 4 days prior to the operation, as there's a risk of euglycemic ketoacidosis. Intraoperatively, what do we do for those people whose glycemic control is not very good and who may require variable rate insulin infusion? We would monitor their glucose half hourly to hourly in theatre, and should they require a variable rate insulin infusion, we would start these individuals. But generally, we would identify these patients pre-operatively. Even in emergency cases, we would decide then really whether they should be on this variable rate insulin infusion anyway. I mean, these are the people who have sort of like poorly controlled diabetes. What about going back on the usual medicines post-op? So the post-operatively, if the person is eating and drinking as usual, then we can start their usual oral hypoglycemic medications. Metformin is not one, not to be given until their EGFR is above 50. In patients who are type 1 diabetics, or those patients who are requiring variable rate insulin infusion, if you're going to restart their medication, what tends to happen is we continue the variable rate insulin infusion for at least 30 to 60 minutes afterwards, as premature discontinuation could lead to diabetic ketoacidosis. But once again, this is something that you need to check with your hospital policy as to what should be done. What I will say is that insulin requirements can change. Also, what tablets you give can change. It all depends on what kind of surgery they're having. Is it minor surgery? Is it major surgery? Is it involving the gut? Is the person likely to have altered food intake post-op? Are they having altered food intake? Are they reducing their food intake? So that means they're not going to need as much insulin, or the amount of oral hypoglycemic medication they're having is not what they're going to need. As a result, that may need to be altered, and so therefore once again, the diabetic specialist team advice may be required. What about people on fixed regimes, like for example the mixes, etc., so you're taking twice a day? So these people should be reinitiated their regime as usual. Once again, the subcut infusion should be continued up to 30-60 minutes after the dose has been given. Therefore, it can then be withdrawn safely. Those on subcut infusions, this should be recommenced at the patient's next normal basal rate. Obviously, the variable rate insulin infusion, once again, must be continued until the next bolus dose is given. This must never be initiated at night. or at bedtime. Other anesthetic conditions, so when we're giving medicines intraoperatively, for example, dexamethasone is an agent we tend to give for antiemesis, but one of the side effects of this medicine is that it can cause hyperglycemia, and so unless the benefits outweigh the risk, the person is going to suffer with severe postoperative nausea and vomiting and ondansetrons and not enough, then really this drug should be avoided. Then there are other surgeries requiring regional neuraxial blockade, central or peripheral neuraxial blockade. With diabetic patients, there's an increased risk of surgical wound sites, so there's a risk of abscesses that they can suffer with, epidural abscesses. So this is something else that needs to be considered when considering neuraxial blockade in these patients. Generally, with the diabetic patient, what is it that can result in poor outcomes? So essentially, that the patient is not first on the operating list. This is the morning or afternoon. The team are unaware that the patient is diabetic. The correct medication hasn't been elucidated or prescribed, or variable rate infusion hasn't been prescribed correctly. These are things that are really, really important to consider. If the patient intra-op has prolonged or persistent high blood glucose sugars, for example, those above 25, or any point during the admission, I mean, that can result in poor outcomes as well. Diabetic ketoacidosis is something in the surgical patient, as well as those requiring overnight stay, especially for minor operations, those requiring overnight stay, where really these patients should not need to do that. If that is required, then this can be another reason that can result in poor outcomes. So in summary, I've given you a quick whistle-stop tour of how patients with diabetes requiring surgical management are managed by the perioperative team. So essentially what is required is a good pre-operative assessment, comprehensive history and investigations. You need a good plan on managing the oral hypoglycemics, insulin pre-operatively, intraoperatively with regards to insulin, the variable rate insulin infusion, and post-operatively on how you're going to reinstigate their normal medication. These patients must be listed first on the list in the morning or afternoon, even in an emergency list. Obviously, if it's an absolute dire emergency, they will naturally go first, but an emergency list and an operating list in an emergency theatre. There are other patients requiring sort of semi-urgent cases as well. So if there's a diabetic on that list, then these patients should go first. And having close liaisons with the diabetic team is essential. You know, they can provide really good advice on what to do, how to alter the insulin therapy post-op, you know, working with, you know, whether the patient is eating and drinking or not, or how much the calories they're having. The dietitian could also have a good input here as well. I hope that's given you a good whistle-stop tour of what concerns that we as anaesthetists, what I as a medic would have when managing patients with diabetes. Thank you very much for your time.